In this video, we will cover the three types of Medtronic valves used for the treatment of hidrosefalus. The first commercial Medtronic valve was the contoured valve, now a part of the CSF flow control valve family. Subsequent to this was the Delta valve, with a siphon control device called the Delta chamber. And most recently was the Strata valve, with adjustable pressure capabilities. We will discuss the variations in design for each valve, including the CSF pathway through the valves, from the ventricular or proximal catheter inlet to the peritoneal or distal catheter outlet. The Medtronic contoured valve. The contoured valve consists of a polypropylene base, a silicone dome, and a silicone membrane valve. The contoured valve also has proximal and distal occluders for selective flushing. Additionally, the contoured valve has radiopaque markings. The dot codes indicate valve pressure level, and the arrow indicates direction of flow. As CSF flows through the contoured valve, it enters the inlet connector, flows by the proximal occluder, and into the central reservoir. For sampling CSF, the reservoir dome can be accessed using a 25 gauge or smaller non-coring needle. From the reservoir, CSF flows through the valve mechanism flow holes. The inlet CSF fluid pressure causes the umbrella-shaped membrane to open when intracranial pressure, ICP, exceeds the resistance of the valve umbrella or membrane. When the ICP is lower than the resistance of the silicone umbrella, the mechanism closes. The thickness of the valve membrane determines the resistance characteristics of the valve. The thinner the membrane, the lower the valve resistance. The thicker the membrane, the higher the valve resistance. These pressure levels have a fixed resistance, which the surgeon selects prior to patient surgery. The contoured valve is available in 4 fixed pressure levels: low, 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 medium, and high. The pressure flow graph shows the threshold at which the membrane will open for each pressure level at various flow rates. These levels are determined by the midpoint on the pressure level range at the typical CSF production rate of 20 to 25 milliliters per hour. For example, if a surgeon is using a medium pressure valve at an average flow rate of 25 milliliters per hour, the valve will have a nominal resistance of 95 millimeters H2O. Therefore, when the ICP is above 95 millimeters H2O, the valve opens and drains. When the ICP is lower than 95 millimeters H2O, the valve closes. Now, let's take a look at the next valve and how it differs from our contoured valve. The Medtronic Delta valve. The Delta valve consists of a firm polypropylene plastic base, a silicone dome, a silicone membrane valve, and unlike the contoured valve, it has a distal delta chamber component, which provides siphon control when the patient is in an upright position. The Delta valve also has proximal and distal occluders for selective flushing. Like the contoured valve, the Delta valve has radiopaque markings. The arrow indicates direction of flow, and the marking behind the arrow indicates the valve performance level. Siphoning, or negative hydrostatic pressure, can occur when the patient stands upright and gravity pulls fluid through the shunt. This hydrostatic situation may result in CSF overdrainage. As CSF flows through the Delta valve, it enters the inlet connector, flows by the proximal occluder, and into the central reservoir. For sampling CSF, the reservoir dome can be accessed using a 25 gauge or smaller non-coring needle. From the reservoir, CSF flows through the valve mechanism flow holes. Like the contoured valve, the Delta valve also has the silicone membrane valve or diaphragm, which opens or closes depending on the inlet intracranial pressure. By varying the thickness of the membrane, the amount of pressure needed to open the membrane valve can increase or decrease depending on the valve and pressure level chosen. After passing through the membrane valve, the CSF reaches the Delta chamber. The inlet area of the Delta chamber diaphragm is greater in size than the outlet drainage port, thus allowing positive inlet pressure to control the Delta chamber, while minimizing the effects of the negative hydrostatic outlet pressure. When the patient is in the supine position, the membranes on either side of the delta chamber are relaxed or open, allowing for CSF flow. When the patient stands up, the negative pressure pulls the membranes closed, reducing the flow of CSF. The delta valve has 4 performance levels, which directly correlate to the valve pressure flow rates. The valve performance levels are 0.5, 1.0, 1.5, and 2.0. These numerical descriptions are synonymous with the valve pressure ranges from a lower to a higher resistance valve. As shown by the performance level chart, the delta valve system maintains a consistent pressure gradient regardless of the flow rate or patient posture. Finally, let's take a look at our third and final valve configuration and how it differs from the contoured and delta valves. The Medtonic Strata Valve. The Strata valve consists of a firm plastic base, a silicone dome, an adjustable valve mechanism, and a delta chamber for siphon control. The Strata valve also has proximal and distal occluders for selective flushing. Additionally, the Strata valve has radiopaque markings to indicate flow direction and orientation of the valve in the X-ray image. As CSF flows through the Strata valve, it enters the inlet connector, flows by the proximal occluder, and into the central reservoir. For sampling CSF, the reservoir dome can be accessed using a 25 gauge or smaller non-coring needle. From the reservoir, the CSF flows into the cone opening of the adjustable valve mechanism. The valve mechanism consists of a ruby ball and circular spring design. At the base of the valve mechanism, there are 5 concentric platforms of various heights. On top of the valve mechanism base is a plastic rotor element which contains a magnet. The rotor element has feet that are designed to engage with the platform stock. Mounted on top of the rotor element is a pressure flow spring which applies pressure onto a ruby ball. The platform design at the base of the valve mechanism requires the rotor to be magnetically raised onto a higher or lower platform through the use of a Medtronic adjustment tool. This enables a surgeon, using an adjustment tool, to set the performance level on the valve preoperatively and make adjustments once the valve is implanted. Depending on which platform the rotor is sitting, the pressure flow spring increases or decreases force on the ruby ball. The higher the rotator sits, the more force is applied to the ruby ball and the higher the valve resistance. As CSF flows through the valve, more pressure is required to push the ruby ball down in order for CSF to pass through the valve mechanism. The lower the rotor is positioned, the less force is applied to the ruby ball and the lower the valve resistance. As CSF flows through the valve, less pressure is required to push the ruby ball down in order for CSF to pass through the valve mechanism. The rotor retention spring helps to stabilize the magnetic rotor on the selected valve setting. Once the CSF passes through the adjustable valve mechanism, it enters the delta chamber. As discussed with the delta valve, the inlet diaphragm area is greater in size than the outlet port area, thus allowing the positive inlet pressure to control the delta chamber while minimizing the effects of the negative hydrostatic outlet pressure. When the patient is in the supine position, the membranes on either side of the delta chamber are relaxed or open, allowing for CSF flow. When the patient stands up, the negative pressure pulls the membranes closed, reducing the flow of CSF. Since there are 5 platforms in the valve mechanism, there are 5 performance levels which directly correlate to the pressure flow rates. Performance levels are 0.5, 1.0, 1.5, 2.0, and 2.5. These numerical descriptions are synonymous with valve pressure ranges from a lower to a higher resistance. As shown by the performance level chart, the Strata valve system maintains a consistent pressure gradient, regardless of the flow rate or patient posture. We have just reviewed the 3 types of valves included in the Medtronic hydrocephalus shunt family. You should now have an understanding of the flow path and resistance characteristics of each valve type, and the importance valve mechanics plays in valve performance. The family of valves have been designed and built with quality and performance in mind, consistent with all Medtronic products, in order to align with our mission to alleviate pain, restore health, and extend life.
The DuraGen graft matrix by Integra Neurosurgery is a unique and proprietary collagen graft for dural repair. Unlike any other system, the DuraGen matrix provides immediate closure to prevent CSF leaks and promotes natural dural healing, providing patients with real dura upon healing. The DuraGen matrix becomes a graft by interacting with the patient's body to optimize the natural healing process. The highly porous nature of the graft, which is 99.3% open porosity or void space and less than 1% solid, allows it to intimately conform to the margins of the dural defect and to complex surfaces of the brain once hydrated. Scientifically engineered pores allow platelets to infiltrate the matrix and initiate a fibrin clot. This rapidly creates a mechanical barrier to CSF leakage and holds the graft in place as fibroblasts migrate to lay down new collagen. As fibroblasts lay the foundation for new dura, the matrix is resorbed completely. DuraGen matrix is manufactured by Integra Life Sciences, a pioneer in the development and manufacturing of collagen implants and advanced regenerative technologies. Integra is a world leader in developing and manufacturing ultra-pure collagen, which has been used in more than 10 million tissue implants, including skin regeneration, chronic and acute wounds, and bone reconstruction. The Type 1 ultra-pure collagen used in the DuraGen matrix and other Integra implants is treated in a unique process that removes all non-collagenous components, including potential antigens and any viral and bacterial contaminants. In 30 years of use, these implants have made a significant difference in the lives of millions of patients, helping them heal with no confirmed reports of foreign body reactions or rejections. DuraGen grafts have been implanted in over 1 million patients. The DuraGen matrix family has the most published clinical support of any collagen-based matrix, including 10 peer-reviewed studies involving more than 1,400 patients. These studies analyzed results from different procedures where DuraGen grafts were used to close the dura. CSF leakage rates from these papers averaged 2.1% for DuraGen products, with a 1.9% rate of infection and 0% rate of foreign body reaction or graft rejection. This low rate of CSF leakage compares favorably to 7.5%, an average of CSF leakage rates found in other studies reporting on complications of dural closure using standard of care in different procedures. Let's take a closer look at the options for dural repair and what makes the DuraGen matrix a system like no other. For years, the only accepted method of dural closure was to use a watertight suture to directly close the dural margins. A fibrin clot would form around the closure to keep CSF from leaking. However, applying direct suture can be difficult or even impossible if the dura is degraded. This technique takes time and concentration, often at the end of a long case. The DuraGen matrix offers a solution when direct suture is not possible or practical. Physicians reported that such situations include older patients with thin, fragile dura that may tear. Cases where the dura has become dehydrated during long surgeries, when large portions of the dura have been resected, and when there is brain swelling and the dural margins cannot be approximated. Why choose the DuraGen matrix over other kinds of grafts? First, grafting with the patient's autologous tissue adds additional time and complexity, and harvesting may result in donor site morbidities. Non-autologous grafts that are strong enough for load-bearing sutures may be stiffer and therefore less able to conform to the convexity of the brain surface, allowing spaces to form between the graft and the brain and potential CSF leakage to occur. Repairing a damaged dura with a DuraGen matrix is as easy as placing the graft directly over the defect. Once the graft hydrates, it becomes a pliable membrane that attaches to the existing dura via surface tension and fibrin clot formation, thus eliminating the requirement for sutures. The DuraGen matrix is highly porous, rapidly absorbing fluids in situ, creating a natural environment for cells. As it gently conforms to fill spaces, the matrix becomes an effective layer between the brain and the overlying cranium and tissue layers, which begins to become integrated after the matrix is positioned and hydrated. As with any technique for dural repair, a fibrin clot forms to seal the dura. What makes the DuraGen matrix unique is the communicating open pore structure, which allows the matrix to fill with blood and plasma exudate. Type 1 collagen is an initiator of platelet aggregation and attachment, and therefore an effective initiator of clot formation. Platelets exposed to the porous structure degranulate to release clotting factors. The fibrin clot within the matrix creates an impervious structure that provides a strong barrier against CSF leakage and binds the implanted matrix to the edges of the remaining dura. So the collagen matrix that was 99.3% porous is now a leak-preventing fibrin clot layer. This slide is a section of a patient biopsy taken 1 day following implantation of the DuraGen matrix. We can see the fully hydrated collagen fibers, the red blood cells in the outer layer, and the open structure of the matrix filled with plasma and fibrin clot. The average pore size of the DuraGen matrix is 50 to 150 microns within the optimal size to allow rapid infiltration by fibroblasts. This structure enables fibroblasts to recognize the matrix as an appropriate environment in which to establish themselves and form new dura. At 2 to 3 days post-implantation, fibroblasts enter the honeycomb structure of the DuraGen matrix from the cut edges of the dura and from overlying and underlying tissues. The interconnected network of large engineered pores provides a scaffold for the cells to rapidly enter, migrate, and attach themselves. The pore sizes and distribution are consistent, ensuring efficient infiltration of cells throughout the graft and thus uniform tissue repair throughout the matrix. The collagen graft promotes fibroblast activity and acts as a foundation for the cells to deposit new collagen. Vascularization of new tissue follows the initial infiltration of the fibroblasts to form fully functional tissue. The DuraGen matrix is less than 1% solid, so the patient's own tissue fills the empty spaces, ultimately making a complete repair. As the new dura matures, collagen is synthesized by the fibroblasts so that the implanted material is completely resorbed, leaving only the patient's own new dura. In this slide, taken 2 to 3 days post-implantation, human fibroblasts are seen migrating into the DuraGen matrix to lay down new collagen. By 60 days after implantation, the matrix is fully infiltrated with fibroblasts, and revascularization of the new tissue is underway. In other matrices, closed porosity, small pore size, or layers of membrane can make it difficult for cells to migrate through the graft, leading to possible encapsulation or scar formation. The DuraGen matrix has been optimized for cell infiltration. A complete tissue membrane is established within 2 weeks of implantation. The new membrane acts as a permanent barrier to contain the CSF, replacing the fibrin clot that breaks down during the normal course of wound healing. The porous nature of the matrix, combined with the type 1 ultrapure collagen, provides a scaffold that is similar to the patient's own native collagen. The fibroblasts do not encapsulate the implant as with many other materials. Instead, they grow through the matrix as if it were a normal part of the patient's body and use the structure as a foundation for the construction of new dura. By 2 months post-implantation, the implanted DuraGen matrix is substantially resorbed and new dural tissue has formed at an appropriate distance from the brain surface and the overlying tissues, creating a new functional membrane without evidence of foreign body response or encapsulation. This is something primary suture repair and other grafts are unable to demonstrate. Approximately 8 to 12 months after implantation, the Neodura has developed into mature functional dura for a complete and natural repair.
Osteonic's CMF products make our appearance look even more beautiful and handsome. It can restore a sunken cranial bone caused by brain surgery. These products are also used for cosmetic surgeries, such as facial contour surgeries and double jaw surgeries.
So what are the features of your company's CMF products?
두 개의 아간면에 골절이나 함본이 생기는 경우에는 여러 가지 경우가 있는데요. 각각의 케이스마다 환자들의 골절의 형태나 모양이 다를 수밖에 없거든요. 이 경우에 오스테오닉은 모든 환자들의 골절 케이스에 대응하기 위해서 여러 가지 형태의 플레이트와 스크류를 개발하고 제공하고 있습니다.
Cerebral Corridor Creator. SYM Cerebral Corridor Creator (CCC) is specially designed medical device for neurosurgeons. It provides a better way to access surgical targets in brain without unduly damaging surrounding tissues. CCC contains a CCC balloon, a syringe, and a tube, with balloon inflated slowly and repetitively by syringe. A tubular corridor is created. The collateral trauma can be minimized, and the tube can make the corridor stability and reliability, which can also protect surrounding tissues during the operation, with the goal of establishing a working corridor in minor brain intervention. CCC can be widely used in neurosurgery, such as hematoma, hidrosefalus, tumor, and other lesions, etc. Without damaging surrounding tissue unduly, CCC makes neurosurgery safer by decreasing iatrogenic injury to brain tissue and brain vessel. CCC avoids complications and accelerates post-operative recovery. Product structure: CCC, balloon brain tissue retraction and corridor creating. CCC balloon consists of an inner tube, an outer tube, a rubber balloon, a three-way stopcock, and a connector. Syringe, inflating the balloon. Tube, maintaining the corridor. The recommended procedure is shown as following. 1. Preoperative preparation. Flushing. Fully flush the balloon and tube with saline before using. Venting balloon. Connect the syringe and connector. Open the valve of connector. Inject saline into the balloon. Place the balloon in low position and inject saline slowly. Deflate after the balloon having been inflated. Repeat the cycle until air is exhausted entirely. Caution: if air is not expelled from the balloon lumen, the balloon may fail to inflate up to its specified diameter. If balloon ruptures, air explosion may result. To avoid this, discharge air from the balloon lumen completely. Stretching balloon. Push the inner tube forward until the pin of the inner tube is locked in the slot. By doing so, the balloon is stretched. Caution: don't rotate inner tube during balloon stretching. That may cause balloon twisted. Connect balloon and syringe. Make sure the saline in the syringe not exceed 10 ml. Push the balloon into the brain tissue along the puncture site. Caution: the maximal capacity of balloon is 10 ml. To avoid damaging the balloon, make sure the saline in the syringe not exceed 10 ml. 2. Pushing balloon into the brain tissue. Three. Inflating balloon. Inject saline into balloon. Inflate and deflate repeatedly and slowly. Be cautious during the process of inflation and deflation. If abnormal incident occurs, stop immediately and take remedial measures. 4. Setting tube into the tubular corridor. Place the tube on the distal part of balloon. Inflate the balloon, then push both tube and balloon slowly into the tubular corridor. Inflating and deflating the balloon appropriately would be helpful. 5. Withdrawing. Deflate and withdraw balloon after tube reaches the predetermined position. Pull out tube slowly after the surgery is finished. 3 warnings. This product contains low-protein natural rubber latex, which may cause allergic reactions such as itching, redness, urticaria, swelling, fever, dyspnea, asthma-like symptoms, hypotension, shock, etc. If one or more of these symptoms are observed in the patient, stop procedure immediately and take appropriate treatment.